Hi, everyone. Welcome. Give everyone a couple of minutes to file in.
I think we're good, Timmy. I'll keep admitting folks as they kind of trickle in, but we don't have any more people in the waiting room.
Okay, great. Well, hello, everyone. Happy summer. I just noticed looking at my video that I'm probably the only one in a sweater in this foggy San Francisco day. So we're enjoying our lovely weather. We're happy to have it. Thank you for joining us today for Connecting for Better Health. We have some great speakers. I'll wait in a second there it is, to introduce them. Kate Ricker-Kiefert and also Lauren Block, who recently published a piece in the California Healthcare Foundation, Investments and Funding Opportunity for Data Sharing. And that paper, I think, could not have been better timed. And also, gosh, we've been needing that kind of playbook for a very long time, and it's going to be a real treat for us to have them walk us through it. And I'm certain that we'll be using it and referring to it over many, many months as we move forward with health information exchange for the state. We also are going to spend some time to review the data sharing agreement. Our staff has been able to walk through it, and we'll provide you what our overview looks like, where there are areas that we need to kind of watch going forward, and then also give you an update on where we are in that process. So I think with that, I'm going to hand it off to, oh, yes, I always kick everything off with our vision, purpose, and priorities. So if you are new to today, I recognize many of you, thank you. But if you're new, and even if you're not, please introduce yourself in chat. Let's use this as a way for networking. We had a great event last night that many of you came to, sponsored by Blue Shield of California, Industry Initiatives. And it's just great to be able to start actually networking in person too. So let's do it still on Zoom here, but let's get the most out of these meetings. So if you could just introduce yourself in chat, that would be terrific. Our policy priorities this year remain unchanged, where we are focused on funding, hence the programming that we have for you today. Also be able to continue our refinement of the data sharing mandate. Again, hence our work today with the data sharing agreement. And then also for us to, continue to keep our foot on the gas, I guess, pedal to the metal as we move forward in this process. And then our next slide too, we want to remind everyone that we believe that there's several key pieces of HIE and data exchange that kind of cross or intersect all of those use cases, those priority use cases that we've discussed, as well as the state has laid out for us. But in particular, we want to really look at this year the data sharing priority cases around CalAIM, which includes social services, as well as our pandemic response to COVID-19 and public health use cases. So those are also what's driving a lot of our programming for you. So with that, I'm going to hand it over to Kate and Lauren. If you guys could also give just a brief introduction, just for, again, in terms of networking and how small our world is. Kate and I worked together several years ago, and it was just so lovely to be reunited. So that's just fantastic too, Kate, for you to be here with us today. So I'll hand it over to you.
Great, fantastic. Let me go share my screen. Lauren, do you want to go ahead and introduce yourself?
Sure. Hi, everyone. I am Lauren Block. I am a managing principal with Arera Health Group. We are a mission-based consulting firm, technically based out of California, but we work across the nation. Most of our work is in the Medicaid space, but not exclusively. And I lead our work that relates to health information technology and data sharing. Prior to joining Aurora Health, I was at the National Governors Association, where I also did a lot of the work surrounding HIT. And all that is where I met Kate Ricker-Kiefert, who was first working for Colorado and then as a consultant with me. So Kate, you want to introduce yourself quickly and then we'll go ahead and get.
Thanks, Lauren. And thanks, Timmy. Yep, I worked for Timmy, oh my gosh, almost a decade ago. I've been in health IT for about 18 years. Worked all the way from a provider and payer at a Corio at the Regional Health Information Exchange. I was also the state HIT coordinator for the governor's office for the state of Colorado. I'm directing their health IT portfolio across 9 agencies, HIEs, APTCDs, every acronym you can think of. And now I advise states and federal agencies on health technology policy strategy. And I helped supported Lauren with the National Governors Association, and I've advised 32 states and 5 federal agencies. So happy to be here.
Thanks, Kate. So we're going to get started by just telling you a little bit about kind of our plan for the session, and then we'll dive in. So we'll start quickly with an overview of what the task was and our methodology for performing the work. We'll talk about the categories of functional needs that we identified from providers, as well as the IT needs by delivery system stakeholders, and then get into the funding sources that we identified that aligned with those needs and next steps. And we'll finish with Q&A. Next slide. All right. So, back one. So this project was funded by the California Healthcare Foundation. And the task at hand really, as a primary goal, was to outline the technological capacity and funding needs of delivery system providers who have to comply with AB 133, and then to align those needs with the ongoing federal funding opportunities that are available either through states or directly to delivery system providers. And it is important to acknowledge that outside of the scope of the project was to look at other funding sources, like private funding sources, whether that be foundations or health plans, and also to think about the technical solutions or vendors who could provide them. So it was really more about what the need is and what the functionality is at a minimum that would support, but stopped short of any intermediaries or other entities that might support it or how they might be funded as well. So important caveat there. Next slide. In terms of our methodology for the project, we primarily conducted interviews. We held interviews with 36 individuals across 24 organizations. That included associations, it included counties, other consultants, and the interviews were conducted before the May budget revised. So most of this work was happening during the winter and early spring. And then we also did desk research. So really kind of looking at different funders at the federal level and what funding was available. Importantly, we also were really only looking at sources of funding that are either continuous or that have several years still to go. So we didn't look at one-year funding opportunities or things that we felt like wouldn't be opportunities in the future. So this is not an exhaustive list that we identified, but it is funding that we think would likely be available for an extended period of time or on an ongoing basis. Next slide. So in terms, while we were doing the research, when we interviewed people, one of the key questions that we asked was, where are you right now? What is the functionality that your stakeholders have right now, and where is the need? And so we identified 4 categories of investments necessary to really achieve robust interoperability. And again, being vendor neutral, but recognizing that people are starting at different places. We found that really across delivery system providers, there's a range of technical service and support needs. We also knew that there are delivery system providers who historically receive funding and implementation support, and they really had the fewest needs. So those who had been incentivized through the federal government or through any previous initiatives really already had the infrastructure in place, and their needs, while they'd have some to stay up to date with requirements and such, but for the most part, those were not the entities that would really need a lot of work to become compliant with the data exchange framework. And so I will go through each of these four categories now. So the first one is one-time technical capabilities and infrastructure. So recognizing that we were talking to public health, hospitals, as well as individual providers and health systems, there's a range of starting points. So we know that most California clinical healthcare providers outside of public health already use an electronic health record, and many of them also use care coordination systems, screening tools. They might have customer relationship management platforms as well as referral platforms that and all of these may or may not be integrated into their EHR platform. However, we know that there are still partners who are leveraging paper-based systems, Excel databases, manual referrals and faxes, using phone and fax, and then also faxing things like lab results. And that was definitely the case with public health, and also the case with others who are sort of on the edge of like healthcare and social services, and who might have systems, but they were not necessarily built for these use. So electronic data capture was one big thing. Electronic data standards as well. So even when the systems can support the data capture, it doesn't mean that they can adhere to common standards. And that can really be an impediment to data sharing for things like, as well as data aggregation for population health analysis. So we know that the standards that might be used in one sector don't always translate to what's in another sector. And so if there's an assumption made that what happens in healthcare is going to happen elsewhere, that may or may not actually end up working out. And then looking at data systems interoperability, we recognize that that certainly is lacking with some systems. So, and that just because two entities are using the same platform, whether that's an EHR or referral platform or otherwise, it doesn't automatically result in interoperability across users of the same system. So there were situations also that we encountered where the organizations can't actually do data sharing, but they can let people remotely access their platforms and have either read-only or edit functionality to one another's systems, but not more than that. So, and then there's also the directed push and pull of data through point-to-point connections. And we know that that can be difficult and costly to maintain, but these were all things we found that were short of interoperability, even if they were workarounds. So that was an issue. Also, adapting single-use and legacy systems. An example here is HMIS, the housing programs system, and systems like this were not built or procured with robust interoperability in mind, and the funding for them doesn't have this broader purview in thinking about uses. And so whether that's homeless systems of care, jails, or smaller physicians' offices, they might have that narrowly defined functionality and have to think about, are we doing something new, or are there workarounds that we can achieve, and how can we get to interoperability? And then, as I already mentioned, the data aggregation and analytics. Certainly for population health management, you need to be able to access data and analyze it. And so if that's not happening in a standardized way, that can be challenging. So that was our first category. That was most certainly the biggest category of identified need that we had. Next is, for the next slide, maintaining new technical capabilities and infrastructure. So we all know that every technology investment requires maintenance, so requires that care and feeding to really sustain high levels of performance and relevance. We did assume for purposes of this project that the state will adhere to federal and industry standards. So USCDI, FIRE, and HL7. And so providers, again, who received prior funds are likely going to need minor systems updates and maintenance as technology evolves. But others who are newer to interoperable technology may really need more resources to maintain their systems and to train staff on the infrastructure enhancements or for new procurements, back to the first point. So then
Hey,
there
Lauren.
was, yes.
Lauren, if I can just jump in here just in terms of timing. I think this group has a good grasp of some of these subsections. So maybe we can keep it at a higher level and come back with questions.
Okay.
Just so that we can get through, because I know we have several slides here.
Sure. So next is just policy and implementation support, thinking about outreach and education that would be necessary, and privacy and security needs. That privacy and security were certainly the highest need that everyone talked about. And then staffing and workforce. So in terms of what's needed there. So go ahead, Kate.
So I think that's me. So what we also did in the paper is we did do tables on what were the specific IT needs by the delivery system stakeholders, identifying whether it was minimal, average, or significant based on the different feedback. So we did go through the different groups and found that there was significant needs in a lot of these different areas. Interesting enough, also whether it was plans or disability insurers or Medi-Cal plans, like there's different things that were needed across the board, specifically the policy and implementation support, that technical assistance and training for privacy or policies, or adhering and really integrating data into the workflow, or adhering and having compliance with the different policies. That was across the board, something that they said was a challenge that was definitely needed. Then also we did go into jails and homelessness, as well as public health. And public health is, they have a lot of things. Obviously, during COVID, they had a lot of findings on the data infrastructure needs and the technology needs. So we'll go into a little bit of details around some of the funding opportunities around those in just a second. All right, this slide, we affectionately called it the subway slide because it looks like a subway match. But there's what I was going to point out with this one is that this by all means is not all of the funding available for technology investments or interoperability or policy and training support. But what this does show is that there's different colors for the different funding streams and what is allowable funding, from infrastructure investment to maintenance to whether it supports policy and technical assistance and workforce staffing and operations. But it starts to show that there are some that go from federal agency to a directed designated state agency, and then that state agency can actually designate and direct funding down to the delivery system level at the county level or at the provider level. And so it just was trying to show a way that there's going to be some that have to go through state agencies to be mediated, and some would be directly available to the delivery system. But sometimes it's hard to kind of map all those things out and see how all that money flows. And so some of the things that we did find within this is, coordinating those different strategies and those funding sources across the funding sources. And there's also an opportunity to align and reuse that infrastructure to really maximize it, because there's a risk of the federal funding silos can also perpetuate the data silos. Might be chicken egg, but it's possible that money would come down and say, you can have funding for technology, and then all of a sudden they are rebuilding technology that might be already there. So that's always a risk that I want to point out to folks. Also on this slide, I do want to kind of talk about, just take one step back to do a little federal funding 101. I'm sure y'all are very aware of grants and the different ways to do it, but sometimes when you have to break down funding and the different sources, you have to have the appropriate authority that is designated, and then they can put appropriations to that different funding authority. And some of those things that are considered for the funding that's available to go through these pipes, it might be a formula grant. So think about a block grant that is based on specific population or needs. and geographic size, those types of things, population size. Some are federal funding participation, where you might have some matching funds. Maybe it's 50% that has to be from state funds, or maybe from different sources. FEMA has usually a 75-25 with a 25% state match. You've obviously heard of high-tech 90-10, as well as Medicaid enterprise systems at 75-25. So some of them have cost sharing and matching funds, some of them don't. Some are also competitive grants that are eligible to specific entities, and they might be limited, like $1 million awards, things like that. So when we go through these different funding opportunities that are there, we identify different ones that are existing or available now. We left off some that are in progress, like CDC's 1815 for chronic disease. It's already year 3 of a 5-year cooperative agreement, so we didn't include that. We also didn't include the COVID relief funds, but a lot of the 5 stimulus bills, they did attach to existing authorities, and a lot of that money has come down, and there's a lot of money around there for technology. So just as a background. So this slide just goes through, and there in the paper, there are details on the funding, the authority, who's eligible, how long is it eligible, and what's the process to do so. So I won't bore you with that here, but if you really like funding, it might be a really dorky table for you to go through. But this table started to go through, and the dark dollar signs are allowable funding, and the kind of lighter dollar signs are around allowable funding with some restrictions. So we went through different agencies, the CMS, different Medicaid funding, and looked at the Medicaid enterprise system funding, managed care, the 1115 and 1915 waivers, and even opportunities around state developed EHR incentive programs. But there are allowable funding methods to actually go after funding for one-time technology. The MES system and that 75-25 is available for ongoing technical infrastructure. And then there's also staffing and workforce that can be included in that as well. There are very specific requirements that you have to do in order to get those, and they have to be organized through your Medicaid agency. But it's not to say that it has to be only Medicaid funds. They can coordinate with other agencies, or they can coordinate with private sector to really build out and maximize those funding levers. But 48 out of 50 states have got high-tech funding, 90-10 funding. So I think that these are going to be some that are going to be leveraged in a lot of places. I also wanted to point out the one at the bottom is around the Innovation Center. So that's CMMI, the Centers for Medicaid and Medicare Innovation. The Innovation Center does have the authority to do a federal behavioral health incentive program similar to Meaningful Use. They have not acted on this. There are at least 4 states who are doing actually state developed EHR incentive programs for specific provider populations that were left out of Meaningful Use, like behavioral health providers, long-term care, as well as rural providers, those types of things. So those are definitely something that folks are working towards. Touching just briefly on this, so CDC has a lot of funding. They also have a lot of funding that is program specific. So it might be infectious disease or non-infectious disease or chronic disease, or it might be maternal health. But there's a lot of things that go through their different programs. So that can be problematic because the money can be somewhat siloed. So there's an opportunity with these to build off of, public health block grant, as well as ELC, or the Epidemiological Laboratory Capacity Cooperative Agreement. There's quite a bit of funding around that state public health agencies can actually tap into to build out the data reporting and infrastructure to help support that epidemiology and laboratory capacity. It's not every state is doing it, but I think that there is an opportunity to maximize it, but it does have to be led by the public health department, since that's how the money flows. There's also the Section 3017 vaccine program that's usually split into 2. That's going to be your adults and your children vaccines. There are very specific program requirements around the vaccine funding. It has to support supply of vaccine. And I'm not just talking COVID vaccine, but like MMR, tetanus, all those different ones. And it has to be specific to the program requirements, but there are some flexibility and priorities that are directed by CDC that can be leveraged for if it's a kind of coordinated strategy on how to maximize, maybe using HIEs and reporting in and having access to vaccine data. I do want to point out this one here. We had to adjust it. We have this paper was published on Thursday or on Wednesday, and this funding opportunity came out like literally 2 hours later. It is an open notice of funding opportunity, or NOFO. It's the Strengthening U.S. Public Health Infrastructure and Workforce Data Grant. It is a 5-year cooperative agreement, 116 eligible entities being state public health agencies, territories, freely associated states, plus counties over 2 million and cities over 400,000. It's very, very specific. It's a formula grant based on population and a number of high chronic disease or high risk areas. And it's $4 billion over 5 years, and it's going to be a big one. It's going to be focused around workforce. There's also the Foundation of Public Health, and there's $200 million in there for data modernization. So there's a really good opportunity to take advantage of that one for a lot of different things. They also have very specific positions around workforce director and data, public health data officer. That's an encouraged but not required position. I also want to point out here the Substance Abuse and Mental Health Administration, SAMHSA. With the COVID relief funding, they did allow for the mental health block grant that's available to states, is that a 6% expansion for a couple of years that would be you could use for one-time technology funding, such as an EHR or a centralized or any particular technical system, but they allowed a 6% bump on the SAMHSA block grant that is could be used for that, and they states just have to put together the proposal on what they need to do there. There is some potential around technical infrastructure, but that is definitely an opportunity around the SAMHSA funding. Again, these aren't the only ones. I could probably list 10 more of the CDC ones. We picked the ones that were kind of active and very specifically brought in technology, interoperability, infrastructure, technical assistance, those types of things, to point out that there are lots of opportunities to braid and blend these different fundings. And other ones we did want to point out is that around Department of Housing and Urban Development, Laura mentioned some things around the homeless management systems. This one has a very specific program requirement around reporting program measures, but the problem with some of those systems is they can't integrate and they don't have interoperability capabilities, but they could have some really good opportunities around population health and really monitoring populations. But this one is very, very specific. There's ongoing funding, but it's for one use and for a lot of reporting up. So that has some limitations there. The Administration of Community Living, ACL, has authority over like the AAAs, the area agencies on aging. As California has their master aging plan, there's an opportunity here that they have some different innovation grants, competitive grants that are available for communities that might be doing coordinated services for social care or support services for aging populations that are very similar to the SDOH work that is happening in CalAIM and other sectors. So just be on the lookout for that. It's an opportunity to align some of those funding streams for the aging populations. And then this also—
that's out there now, or you just said keep a lookout for it?
They awarded some last year, and I think that they had recent NOFOs that might have just closed, but they are at the federal level, ACF, which is Administration of Children and Families, CMS, and ONC and HRSA, they tend to start to align those, and they're aligning a lot of the requirements around that social data exchange.
Right.
Right, and the round 3 applications have closed, and they have not announced anything new as far as I'm aware.
Mm-hmm.
Thanks,
Yep.
Courtney.
But it's a one that folks don't normally kind of go and watch. Sometimes you look for competitive grants with ONC or CMS, and it's just it's as the populations are getting older. These are ways where these programs might be supporting different populations and programs, but they're still the same person. They're going to be touching these different systems in different ways, whether for healthcare delivery or support services, or maybe for some benefits like SNAP or TANF. So there's some ways that we can start to align these. I also want to point out BJA, just because it doesn't fall into HHS, but Bureau of Justice Administration always has a funding program around prescription drug monitoring program. CMS had 100% federal financial participation for the Support Act, which is 2 years at 100%, saying that they would just give money to the states, go do some things. And there was a ton of flexibility around technology and infrastructure. 15 states got the Support Act funding, but if there are some things around opioid addiction, opioid data, prescription drug monitoring programs, that BJA grant is a good source as well. There are some restrictions around those, as with most of them. The other ones here are just another examples around some HRSA funding. HRSA does some funds for the community health centers, which I think is important to show that you have different networks. You're going to have your national networks, like with the QHINs, the Quality Health Information Networks. You get your HIEs, but a lot of the federal qualified health centers have their own networks to support the community health centers. So how can you layer that in? And maybe there's some shared infrastructure that could be available. Again, a lot of these have a one-time technology investment. Not all of them have that ongoing technical infrastructure. So it's how do you strategize which ones can support that ongoing maintenance, and where are there opportunities to have some of that shared infrastructure investment. FCC has some things around the Healthcare Connect Fund, Rural Healthcare Program. They've obviously got a lot of things around telehealth. It's always something to look for there. FCC has a lot of funding coming down for broadband and really trying to close that digital divide on broadband, which is a key component for the technology. And the last one there was around the HUD, the Homeless Systems of Care and Continuum of Care. They do have some funding for some ongoing infrastructure, but again, if you kind of map the needs of the stakeholders to where the funding is coming from, it's really a lot of braiding and blending to maximize these federal resources to really, put together the tapestry to fund the technical infrastructure. The last thing I want to kind of point out here, I think, is around some other state funding examples. We did reach out to Washington, Maryland, and Nebraska. They've got some creative ways that they were able to fund different activities and investments for one-time technology and ongoing infrastructure. Washington State is awaiting certification for their CMS operations funding at that 75-25 rate, which means they've had to do their measures and their certification. It takes a long time. I've heard some states can take 6 months to 2 years to go through that process for maintenance funding. So they're awaiting certification. They also have 90-10 funding for public health going forward for a kind of a coordinated system. They also have their 988 tax, which just was launched nationally a few days ago, but they have state legislation that puts a tax on new cell phone numbers and regular telephone numbers, and it goes into a fund that pays for EHR as a service for behavioral health providers and helping that connect that system for that 988 suicide service to help support the operations in that call center service. So kind of connect the dots on, if you have this technology and you're supporting it for mental health needs, it might be a way to connect some of those gaps in your infrastructure. Maryland has had operations funding from CMS for a couple of years. They also have investments in their state PDMP funds, BJA grants, and they also attach it to their payment models. They have a global budget model with CMS that they're able to do requirements for using the data and analytics, but that is a way that they've been tackling some of a multi-payer approach using payers to participate. Payers have an opportunity to do medical loss ratio and invest in some of their digitization and digital investments for quality improvement. So that's a way to offset some things, but it's how do you connect that private sector, public sector, and braid this all together. And then finally, Nebraska, they're awaiting their certification. They do a lot of CDC funding streams. 1815 is the chronic disease, opioid funding for their PDMP, data modernization. There's a lot of money that has come down through the COVID relief funds for that. But again, a lot of the DMI funds have been very focused on COVID related activities, and they haven't always been flexible for that, maximizing it. But I think the new grant with the strengthening US public health infrastructure, I think goes beyond that, and that's going to have a lot more flexibility. They also do some interesting things around reinvestment funds to offset some of that state match difference. There's a lot of different creative ways that you can do that state match. It doesn't have to come from general fund. I've seen it come from philanthropy. I've seen it come from state agencies. There's even places that do the match off of a state health IT tax that the payers contribute to. And there's even a state that does a PMPM calculation from the payers that do that offset of that state match. So just some state examples. So looking forward, and Lauren can chime in here if I missed anything, I think there's opportunity for a coordinated strategy in aligning your initiatives and investments, whether at the state level as well as at the county level. There's also the need for that technical assistance, that policy and training support for those technical implementations. Reuse the investments. There's not, just because a funding stream says you can invest in something, there's an opportunity to reuse something that might be already in the community or maybe in the community next to you or at the state level. There's also opportunities. There's some states that did a funding czar that coordinated all the different funding that was coming down to the states to make sure that there was, just how everything was lining up and what was being done. With the original high-tech money, the ARA, they required every state to have a health IT coordinator. They don't have that requirement anymore, but there's an opportunity to coordinate the funding, the strategy, and the data just to really maximize those things. And then also for the technical investments, sometimes it's not just that one-time investment. How are you going to plan for your operations and your program and your technology needs? And it's all of those costs around those technical investments. I wish it was just, a referral platform, but it's all of the implementation and operations and the people and the support around it that should also be factored in. Lauren, did I forget anything?
No, I think that's about right. The only thing I would just add is that, to your last point there, just making sure that sometimes the technology is kind of, people overlook it and they do all the other requirements and not thinking about how the data that's going to have to be collected or otherwise is actually going to be transferred. So our big thing is making sure it's not an afterthought, but I know that's preaching to the choir here, but it was certainly a takeaway.
I think the last one was just a summary, and also within the paper, we did go through, again, this was done kind of earlier in the year, we did look at the 21-22 budget, and it was identified a few different places where technology was included, the master aging plan and a couple of other things, but looking forward, there's some things for health IT interoperability, HIE work that is in the 2023 budget. And there's definitely opportunities to continue that coordination across the state, investments with the general fund, but also some of those federal opportunities that have a lot of funding continuing to come down. And these are our contact information if you guys want to reach out. And Timmy, anything else? Do you want to go for questions and answers?
Yeah, I'd love to open it up for questions. I'll get us started with just, did you, as part of this work, did you or could it be done where we can inventory what California is already tapping into versus what kind of is shovel ready to go versus what could be, the best case future that's going to require some work? Have you thought about it in that way or?
Mm-hmm. In the initial research, we did look, we started kind of with the COVID relief funds and say what money has already come down. And when we kind of narrowed it down to, instead of doing like small, $500,000 grants or $2 million grants, we started to look at what were some of the continuing funding streams that are continuous and then also ones that are open and available now. We did pull some of that information of what are the numbers that California currently receives. So we do have that for a lot of these different funding sources.
Can we follow up with you on that? Would that be okay? Okay, great. Other questions from the group? Did I see anything? Okay, well, this has been fantastic, and I know it'll be a reference document for us. And, I also think that it can be really useful for us, all of us, to refer to it and make sure that our colleagues, and especially those that we work with in government and our government relations colleagues, have this as in their back pocket too. So if you have any questions going forward, I think, definitely reach out to Lauren and Kate directly, or we're happy also to facilitate and make sure that we get you the answers that you need. So thank you for being here today, and you're welcome to stay while we walk through some of the data sharing agreement work.
Sounds good. I'll stop sharing. I'll put our contact information in the chat for folks too.
Oh, perfect. That'd be great. All right, Robbie, I'm going to hand it to you.
All right. Thank you so much, Lauren and Kate. Yeah, I think just jumping to the Cal HHS data exchange framework, the documents were released last week on the 5th, which was really exciting to see. And I think what we'd like to do here today is just walk through in particular some of the key pieces of the data sharing agreement and the policies and procedures. We know we've gone through, a lot of this content before, so kind of want to focus on some of the highlights and the changes that were made, and then, what issues, legal or policy or otherwise, kind of remain. And as well, we're working on a more robust fact sheet that will come out of the conversation today and provide more of an overview around the data exchange framework and the sharing agreement and the like. So just a couple items here. So around the requirement to exchange health and social services information, not much of a change here. I think one of the outstanding issues that we highlighted in our comments and that Cal HHS has noted as something that they'll be working on is around defining real-time data sharing under AB 133 and what that means. And we'll be looking to develop response times in a subsequent policy and procedure. As well, around data elements to be exchanged, folks brought up, US CDI version 1 versus 2. I think they were responsive to that. They did mention US CDI version 2 in the final PMP around data that needs to be exchanged, and have been open to, making sure that, standards get updated in these documents as standards evolve, to make sure that they're, as evergreen as they can be and up to date. I think diving into, permitted, required, prohibited uses, there's a lot of, discussion at the meetings around these, specifically with a healthcare HIPAA frame. And we provided some comments too. On the issue around healthcare operations, so I think the issue initially here was that the policy and procedure around uses only included a subset of healthcare operations in it. There was discussion around, expanding this definition and, also incorporating, corresponding HIPAA requirements around authorizations, and Cal HHS signaled that, they're open to making some modifications to this to kind of clarify and align with HIPAA as well. Around financial benefit, I think this was a big change. So one of our comments was around the previous language and the draft that was released before the final around, prohibiting any sharing that might lead to indirect or the use of that data for any sort of indirect or direct financial benefit, and that was too broad of a language. So they have updated it to specifically prohibit the use of data shared under the data sharing agreement in order to sell that information. So they're a bit more specific in terms of what they'd like to prohibit. I think that does, in some ways, it goes beyond obviously federal law and HIPAA, but also existing state law too. And I think, some changes will be needed to certain provisions of state statute just to make sure it aligns with the data sharing agreement. And then additionally, there is an exception around charging fees for health information organizations who charge fees to their participants. So that's an explicit exception that's been allowed when it comes to the prohibition on charging fees to share information under the data sharing agreement. I will go to the next slide. A couple other items, breach notification. So I think many of you remember they had previously, a 72-hour notification requirement before, and a 10-day written report of breaches. It really went above and beyond what's in the California code as well as HIPAA. So they've removed that language and stated, that they will breach notification needs to reflect timeframes within existing law. They also removed language around needing to notify likely impacted participants, which was, kind of vague, I think, to a lot of us in terms of who do you got to tell about a breach. Additionally, individual access, a lot of this is the same. They clarified some of the responsibilities around providing data that is available versus not. So I think making clear that a participant, a signatory to the data sharing agreement, doesn't need to go and hunt down data from other organizations or other participants in order to get an individual their data. That if they have it, they need to provide it, or if they know where it is, they need to provide the individual with, a notification of where that data is to the extent they know where it is. And then I think too, just a couple other items, minimum necessary, they did still include in here an exception if it's not feasible for a participant to meet that standard. Which isn't entirely defined at all in terms of what that means if it's not feasible. And they have clarified otherwise that, signatories to the data sharing agreement, even if they're not a HIPAA covered entity or business associate, need to meet the minimum necessary standard unless they fall within an exception. And then additionally, just around privacy and security as well, they still have the warranty language around HIPAA compliance, which I think is a tall order, warranting that you're meeting HIPAA privacy and security standards at all times. But as well, there is, I think, some conflicting language around the minimum necessary exception, which requires compliance with the HIPAA regulations as well at all times. So I think there's maybe a need to kind of clean up some of that language at a later point in the PMPs around privacy and security. Just to highlight, what are some of the outstanding issues that, weren't addressed in the current drafts? Qualification process for HIOs. They said that they are looking to get to that in a subsequent PMP. As we mentioned, a definition of real-time exchange, as well creating statutory authority for the governance model that Cal HHS plans to stand up for the data exchange framework going forward. And then also funding for onboarding. And Cal HHS has recognized the need for resources for data sharing, and that's something that they will be pursuing in the future. And just to refresh folks' memory, I know we showed this last time, but they will be transitioning to a new governance model this summer. In the interim before, they ideally, move to this statutory-based model. They'll have an implementation advisory committee, as well as a PMP subcommittee that will advise Cal HHS in the advisory committee as well. But I know that was a lot. I guess I'll stop there and see if folks had any other thoughts or reflections or things you might have noticed in the DSA or the policies and procedures that stood out to you as remaining issues as well. All right, well, we'll make sure to get that fact sheet together. If you have any other questions or comments, feel free to send them to us, and we're happy to dig in even more. And I think big thanks to everyone who's weighed in to this point on the comments and the analysis of the meetings too.
And we've put an invitation out to John Ohanian and also Rim Cothran to attend one of our meetings in August. So hopefully we can have them real time and you can prepare your questions for them. And Robbie, I think you're going to talk about this, but the identity work is supposed to come out. There you go.
Yeah. Just to highlight again the PMPs that are going to come out this year. These are the ones they listed at the last stakeholder advisory group meeting. So again, qualification, real-time sharing, and then other things like enforcement, monitoring, and the like. So yeah, and then end of the month is when the digital identity strategy is due.
So hopefully we can, we have a couple weeks off here, but in August, we can make sure that we prepare for you what's released for the identity management and make sure that we're, mark your calendars because we'll need to go over that in detail as well. And we haven't, Robbie, we haven't seen anything or has put it out to all of you. Have we seen anything around the selection criteria or how to apply to be on the advisory committees going forward? Nothing.
Not yet. Not publicly, at least.
So if anybody has that information or if we see it, let's make sure that we circulate it so that we can get it out to everyone as quickly as possible. I'm sure there's going to be some tight deadlines.
Yes. Awesome. I think just a reminder, we've got a new meeting series. We got good turnout today, so excited to see the Zoom registration worked again. But just to note, our next meeting won't be till August 11th. Just taking a few weeks off because we know many of you are going on PTO or vacation. And so we'll start to tee up, our next guest presenters for subsequent meetings. So please do make sure, if you download the meeting series, you've got the right dates. I know we haven't solved calendar interoperability yet. We're going to need to connect for better calendars at some point. But, if you can just double check the dates, because I know for some folks with some calendars that some of the dates were off or it was downloading as a weekly meeting.
And we're happy to work with you one-on-one on that too.
And I think too, just on the topic of the data exchange framework, I think has been noted in a lot of meetings. It's the framework and the sharing agreement have been really focused on health, and I think less on the social services or social care side. So we would love, I think, as we've mentioned before, but we're moving forward with it in terms of hosting workshops, focused on needs when it comes to data sharing, policy needs, with a focus on social care organizations in California. We'd love to have a targeted focus on, specific programs in specific counties, because we know often in California, policy and governance can get localized. So we'd love to, I think, focus on homelessness, women, infants, and children, area agencies on aging, in specific localities. We would love to partner with you or involve you in the planning process. If you're interested, I think we've identified a few folks on this call for outreach. But so far, ITUP has expressed interest, as well as Blue Shield of California, in helping to host these workshops. And these will be open to the public, but we certainly want to make sure, from those counties and those programs that we get, key folks to help lead discussions, to really highlight, some of the bright spots as well as some of the existing needs. And I think as an output, be able to put together the takeaways and the recommendations from those workshops and share them with Cal HHS and the Implementation Advisory Committee as they, proceed with, further revisions to the PMPs and create new funding opportunities, making sure that we also highlight the social care voices in the conversation too.
So Connecting for Better Health is going on the road with these workshops and hopefully pulling together at a local community level. And I think it's just going to give really good feedback for all of us, as well as the state, on where there needs to be some additional focus. Yes, Doug.
Yeah, I was wondering, the policies that we're helping form here and getting involved, becoming on the committees and stuff. Is anything going to be governance over, like right now, Fitbit and Connected America and Jitterbug and some of these programs that are, I focus on the seniors and stuff like that, but that are consumer electronic exchange type of things going on. Is anything going to affect how they have to participate in exchange with my provider networks? Is there going to be any legislation on that? Because I mean, right now they just are doing anything they want. And I'm wondering if there going to be some type of standardization in rules that they have to play by, because we're obviously under stringent rules, but this whole commercial industry seems to be immune to it.
Well, so right now they're not, a company like Fitbit wouldn't be required to sign the data sharing agreement. I think they've really specified providers and health plans as the required entities that have to sign on, but that doesn't mean that those companies wouldn't be subject to other state privacy laws. There's certain requirements or thresholds that companies have to meet to be subject to some of those laws, like under the Consumer Privacy Act and the like in California. So I guess the answer is it depends, but we'd be happy to follow up with some resources if that would be helpful, Doug.
Well, and I also think that's a very good, call out. And as part of, an outcome of these workshops, I think we can say, here are some big questions, or, here's the big boulders that we're also dealing with that we need to either put in the parking lot or, tackle very soon. So appreciate that insight. So I think the action there, Robbie, just to raise your hand. Doug, I see your hand raised. But if you would like for us to follow up with you to be part of the planning process, we're really focused on getting these accomplished in, I guess, the August and September timeframe. We had hoped to do it in July and August, but I think it'll be more practical to have it be done in August and early September, 2 in August and 1 in September. So we're moving very quickly on this. We really appreciate your support. So either text us here if you'd like for us to follow up, or if you have our emails as well. And thank you to ITEP. I see you're on, and Blue Shield. Okay, let's go move on.
Yeah, I think just a few other announcements. Manifest MedX is having a webinar on July 28th focused on data sharing and health equity. So we've hyperlinked that here. There's also an ONC workshop on e-consent in mid-August too. I'll be tuning into that and hoping to learn from the panelists there, but wanted to highlight that for folks. There's also a new ONC data brief out on healthcare interoperability from 2019 data. 65% of physicians participate in some form of HIE, but I found that the other 35% who are using paper-based methods for data exchange was something that stood out to me, but recommend folks check that out too. There's also a new National Academies discussion paper out on digital health that also calls out health information exchanges, a key component of digital health in this century. So we can link that here too. There's also a new pediatrics informatics collaborative in California that's formed really to bring together pediatric providers related to compliance with the 21st Century Cures Act. How does that, how do those requirements around patient access and information blocking, how do we balance those with, state laws and confidentiality laws when it comes to children and adolescents? So we've reached out to some folks there to join us at one of our upcoming calls. As we mentioned, Cal HHS digital identity strategy will be out later this month. So we'll have an update at our next meeting. And let us know too, in addition to those workshops, if you'll be at the Civitas conference in August, we'd love to get folks together for a dinner that Monday. So let us know if you'll be there. We'd love to kind of get a head count and get folks from the coalition together. Any other updates folks would like to share at all?
Anything we missed? Okay.
Awesome. And good. We'll see you at the ONC workshop, Christine.
Yeah, great, Christine. That's going to be a good one. All right, I think we're at our time. You'll see our calendar of events. Reminder to everyone, we're taking a bit of a break. Enjoy the next few weeks. We'll see you on the 11th. And in the meantime, too, let's keep the emails going. Push us information that we can get out to everyone, and we'll keep you posted if we hear anything as the DSA continues to evolve. All right, thank you, everyone. Have a great day. Take care.
Everyone.